I'd like to introduce our first speaker, Professor Stephen Boyages. Dr. Boyages, he was with us last year and he gave us a very good rendition about dietary control and management in the new world. He's going to give us a bit of an update. He's an endocrinologist and clinical professor at the University of Sydney and the University of Western Sydney, world-renowned expert with decades of experience, and I present him to you today.
You sound old. Well, good morning all, and it's great to be back, and thanks to Michelle and to Bill and to all the members of the group. It's great to see everyone up so early. I suspect you may have all had a late night. I'll be talking about a hot topic of weight loss, which obviously plays into the cosmetic aspects of the whole patient. And I'll give you a little bit of an update as to where the field has moved in the last 12 months. It's a rapidly changing field, as you can actually imagine, and it's a field in hot demand. So that's what I'll be talking about, and hopefully there'll be some time for questions at the end. We know that obesity continues to rise. It's a reflection of our economic development. Having done a lot of work in China, when I first worked in China, there was no diabetes. Diabetes was unknown. Everyone rode a push bike. There were hardly any cars on the road. And now, if you go to China, the prevalence and incidence of diabetes is actually massive. Why? Because their economic affluence has increased, and as they become more affluent, they have access to better nutrition, higher energy foods, and we're all designed to see food and store energy. So this is just a part of our natural evolution. So when patients come along to me and say, I'm gaining weight, it's the menopause, it's my thyroid, it's never really all of those things. It's generally their level of energy intake. It always comes down to that. And I normally say to patients, you're not a nuclear reactor. You cannot create energy. You cannot create mass. So whatever mass you have has come from somewhere. And a very simple message that I give to my patients is whatever food you carry into the house, there's only two ways out of the house. It's in your mouth or in the bin. So say hello to the bags of food that you bring into the house, because it will be you in the near future. So some very simple exercises. The second problem that we all have as humans is that we're designed to eat. And again, that's an evolutionary thing. Whenever you see a nature program on the TV, what are the animals all doing? Eating and generally reproducing. Okay, so and we're not much different in terms of the animal evolution. So we're fighting eons, centuries, millennia of evolutionary drive and hormones that make us want to eat. So pure willpower will not do it. So what we'll be talking about is some of these new drugs that actually address some of the hormonal mechanisms. That obesity, you hear these figures every week on the radio in some manifestation. Our country is becoming heavier. 1 in 3 adults at least are probably technically obese. People are trying to change the definition of obesity and make us all feel a little bit better. 2 out of 3 are technically overweight. And it's like a superannuation account. As we all get a little bit older, we all get a little bit heavier. And once you get beyond a certain point, say about 80, it's good to carry a little bit of extra energy reserve. And all fat is basically stored energy. And that's the other metaphor that I give my patients. It's like your battery on your phone. It's simply stored energy. So what are these glucagon-like peptide agonists? They're basically molecules that work on the brain, they emanate from the gut, and they switch off appetite. They regulate insulin, they regulate glucagon, and they regulate gut motility. And they're some of the reasons why we get the side effects of the compound, because they work on the gut. So the commonest side effects of these compounds are nausea, diarrhea, or constipation. So many patients complain of nausea. So when they take the drug, they keep trying to force feed themselves. And the stomach just simply can't cope. So it's simply a matter of reducing intake. So what have we seen in the last year? Well, there's been approvals of a whole range of new drugs, both in Australia and internationally. New indications, which I'll touch on shortly. Increased global availability, although there's still shortages of some of the drugs, particularly for some of the indications such as diabetes. Some of the companies, insurance companies now cover them, particularly in the US. Everyone complains about the price of some of these compounds, but we have the cheapest GLP-1 agonists in the world. The lowest price you can get it for is for about $130 off PBS. In the US, that same drug is $1,300 a month. So we get it for $130. In the US, it's $1,300. The non-diabetes version of semaglutide, which we call Wegovy, is $260 a month. Now, again, it sounds like a lot, but it's $10 a day. You cannot buy a muffin or a cup of coffee these days for $10, and you save the money on the food that you don't purchase. So that's, again, what I say to my patients going forward. So what's been the impact? The impact is phenomenal in terms of the amount of weight loss. So what we're seeing on average is 10% weight loss in 6 months. We're seeing on average 15 to 20% in about 18 months. And some of the new next generation compounds will achieve up to 30% weight loss. So it's equivalent to bariatric surgery that's designed for actual weight loss. So they're having phenomenal impact on our patients with diabetes and all the other comorbidities of obesity, such as fatty liver and cardiovascular health. And we're now seeing obesity, and we'll come back to the mechanics of this and the implications of this, as really as a chronic, I won't call it disease, or a chronic condition. And we know that if you lose weight, a lot of the metabolic complications, and this slide's a little bit complex and we don't need to go through all the detail, but a lot of the manifestations of carrying extra weight, such as diabetes, fatty liver, high cholesterol, high triglycerides, high uric acid, will be reversed, and it's potentially reversible. So this is what I say to my patients. So I have patients who come in feeling very glum, saying, oh my God, it's terrible, I've got diabetes. I say to them, you can reverse this, and all of a sudden their eyes light up and they're super keen and interested in terms of taking it forward. So these are the ones that are available largely in Australia. We've had Saxenda, which is that third one on the list there. We've had semaglutide, and the new kid on the block at the moment is tirzepatide, or Mounjaro. There's a bit of confusion in the market at the moment because semaglutide comes in 2 flavours. It's identical. So Ozempic is designed for people with diabetes on PBS. Wegovy is the weight loss version, and it goes up in terms of strength up to 2.4 milligram. Ozempic only goes up to 1 milligram. So they're both the same drug, made by the same company, except Wegovy costs twice as much as Ozempic at the equivalent dose. But again, it's about $10 a day. Tirzepatide, the only name we use in Australia is Mounjaro. In the US, they use Mounjaro for diabetes and Zepbound. Don't ask me where they get these names from. Zepbound for weight loss. But in Australia, it's simply called Mounjaro. It's not actually on the PBS for any indication at this point in time. Only available for weight loss. Can be used in diabetes, but the cost is slightly higher, about $285 per month at the starting dose, but it goes up to $750 a month for the highest dose of 15 milligrams per week. And all of these agents, except Saxenda, are weekly agents. Small little needle, quite painless, once a week administration. There are newer agents called triple incretins. So these are what we call GLP-1. There's lots of acronyms, GIP and glucagon receptor agonists, which are in the pipeline, which will be hopefully available in the next 12 to 24 months. And these are associated with about 30% weight loss over a 12 to 24 month period. So quite phenomenal compounds. So these are first generation, second generation, and the triple agonists are third generation compounds. Fantastic drugs, have revolutionized what we do, and what we now recognize, it was never really about willpower, and that's why groups like Weight Watchers have fallen by the wayside, because it's not been about willpower. And you saw Oprah Winfrey, who was an ambassador for Weight Watchers, come out and basically said, I'm on Ozempic. And if you look at Elon Musk every second day in the White House, he's looking skinnier and skinnier, and I suspect, and he's actually publicly stated that he's also on Ozempic. So what are the effects of Ozempic? This slide simply shows one of the many trials with semaglutide. These are what we call step trials. And you can see in the, if I can get this little pointer to work. So no, I just don't want it. I just want to lasers. Lasers not working. Okay. So basically, you can see that graph. The top line shows placebo, and the bottom line shows the effect of semaglutide. And in this study, it was around about 14% weight loss over a 65-week period. Again, phenomenal impact in terms of the effect of the drug. This is tirzepatide, Mounjaro. Again, about 16.7% weight loss. In some trials, it's as high as 22.5% weight loss in terms of people achieving significant, more than 20% body weight loss. And you can see the effects are almost within 6 months. You're getting about 10% body weight loss. And I'll describe what patients actually feel. Now, there's big debate at the moment as is Wegovy or Ozempic better than Mounjaro or the other way around? And there was a trial that came out at the end of last year at JAMA that basically indicated that, oh, thank you. Yep, top one. That basically showed that the blue line is Mounjaro, the yellow line is semaglutide or Wegovy. In head-to-head trials, Mounjaro is actually somewhat stronger than Wegovy, but there is a slight cost difference. So we often change our patients from one to the other, particularly if patients achieve plateau. Now, these are the potential side effects: nausea, vomiting, constipation or diarrhea. If you dose escalate slowly, generally the side effects are well tolerated. Very few patients actually come off the drug. There's a lot of scare media actually out there talking about the dangers of these compounds. We have thousands of patients on these compounds, many patients a day who are coming in on the compounds. I can probably count on my hand the number of patients we've had to take off the medication because of side effects. It does not cause thyroid cancer. If you're a rat, it causes thyroid cancer, but if you're not a rat, it's actually safe. It doesn't cause thyroid cancer. The injections are very minimal. I mean, particularly in your industry where you're probably giving more injections than once a week, they're actually quite minimal, quite painless. So again, demonstrated to the patient. We'll talk about weight regain, and the issue of cost is the issue, but again, it's how you present it to the patient in terms of cost going forward. Now, the interesting thing is one of my patients came in last week and she just said she'd been on the drug for 3 months. She lost about 12 kilos in weight. She said for the first time, and I had 2 patients who said this to me in the last week, for the first time in my life, the food noise is gone. And what she meant is I wasn't sitting there thinking about food day in, day out. Not only getting hungry, but also getting hangry. Coming home, yelling at people, yelling at a partner. Partner says, it's fantastic, you know. The food noise is actually gone. And this is what patients describe. The food's there, and there seems to be a disconnect between appetite and then starting to eat and thinking, well, that's enough. And I've had some people say, it's so sad now. I look at the food and I think, geez, I'd like to eat that, but I just don't feel like eating it. So it's an interesting phenomenon in terms of what patients are describing. So it suppresses appetite, increases satiety, slows the gut down, and constipation and sometimes bloating are some of the common side effects that people describe. So they're not thinking about food, they're having smaller meals, they're not chasing food. And you know, typical male comes home, first thing they do is they go to the pantry, shove food into their mouth, sit down, have dinner, then go to the refrigerator after dinner, have more food. Generally, the wife says, or the partner says, why are you still hungry? And then they fall asleep in front of the TV watching Netflix. So it reduces all of those types of behaviours. And we know now, we have numerous trials showing the impact of these agents on cardiovascular health. The drug has actually just been approved to prevent heart disease as well as obesity. We can fix fatty liver, that's what NASH stands for. And probably it's starting to demonstrate some effects in terms of neurocognitive dementia, inflammatory disorders patients are reporting. I had a patient 2 days ago who had terrible eczema. After 3 months on this drug, the eczema completely dissipated. So we're seeing lots of broader effects. We can see remission with type 2 diabetes mellitus, and that's what we're actually aiming for these days. There are new agents on the horizon. Some of them are completely unpronounceable, and these are oral agents, some of them. They'll be available in the next 2 years. And again, the top one there, I'll try to pronounce it, the orforglipron, is basically a tablet, quite a different mechanism of action, again associated with about 30% body weight loss over a 12 to 24-month period. Semaglutide, which is the oral version, Rybelsus, not available in Australia but available other countries around the world, is also an effective agent. And on top of that, in the pipeline, there are other agents which are coming out which are not only weekly but monthly and twice yearly agents that will revolutionise the way we actually manage this particular problem. The problem is the potential cost and subsidy, and companies are trying to get governments to subsidise this. There's limited coverage in terms of insurance, and there's problems with availability, particularly for the agents that are subsidised for diabetes. There's some ethical considerations that we need to think about. Should we put this in the water supply? Probably not. Should we make it available for everyone on Medicare? Maybe. Will it save dollars? Probably. Can we afford it? Probably not. Companies are potentially greedy, so the impact on health budgets is a big issue. And then the issue is people who aren't particularly overweight. A little bit of extra fat, should we be using it in these patients? Because the indication at the moment is in people who have a BMI of at least 27, if you're non-Asian, and maybe lower. So should we use it in people who are just a little bit overweight is an issue that we are not certain about. We don't know some of the longer term side effects. The agents have been, as a family, have been around for about 10 to 12 years. They are probably safe long term, and one of the discussion points that we have is, should we continue these agents long term? Like a statin, like a cholesterol lowering tablet, should they stay on it for a long period of time? What do we do with patients who are using it for pure cosmetic reasons? And then should we just focus on using medication and not lifestyle? And I'll show you some slides highlighting that. This is one of the bigger problems, and patients are aware of this. You get weight regain. It's not instant. You don't wake up the next morning and all of a sudden you've gained 10 kilos. It's a slow reaccumulation of weight, but you can prevent that. Generally, I say to my patients to stay on it for at least 2 years and then slowly taper the dose down and withdraw. And by that time, hopefully, you've relearnt new eating habits. Lifestyle still is important. You're going to get better bang for your buck by eating less. If you try to keep eating the same, it's not going to do much more than any other standard diet. It's not magical. It doesn't strip out the fat out of your body. It doesn't do that. It doesn't suck it out. It simply reduces your appetite and you end up eating less. That's the only way it works. Exercise is important to maintain muscle mass, healthy heart, balance, bone strength. But again, exercise by itself is not going to make you necessarily lose weight. You need to have some strength training and maybe some behavioural therapy as well. We will identify in the future new ways of addressing these problems, particularly as we better understand genomics, and we can then tailor certain agents to certain individuals. I'm sure it won't be one size fits all into the future. And we'll discover new combination therapies that will be increasingly successful. I've mentioned this in part. We'll have better agents, more availability, an expansion of indications. For example, sleep apnea, which is a disordered breathing problem, has now been approved as an indication for Mounjaro or tirzepatide in the US. For an audience like this, it's an opportunity, I suspect, because many of these patients lose weight and then they start feeling better about themselves and they want their skin and the rest of themselves to look better. And again, you probably can tell me better in terms of what to do. But rapid weight loss leads to loss of muscle, not in proportion to the loss of fat, but you do lose muscle, you do lose some facial features, and you get some of these what we call Ozempic facies. Patients have loose skin and then they're looking for plastic surgical options in terms of addressing that. You do lose hair short term, and there are again ways of addressing that. And then we talked about sort of muscle. So there's some of the things, and you can probably tell me more in terms of what we should be doing. But again, I think there's an opportunity for groups like yours to be working with the weight loss groups to actually work out how to deliver this as an integrated package rather than as a disconnected set of services. Interestingly, and there was an article the other day I was reading that a husband was completely upset that his wife had lost, very upset that his wife had lost 30 kilos in weight. In fact, it was written up in one of the medical journals. He felt completely distressed, depressed, was no longer having sexual intercourse with her because she was not as cuddly and curvy as before. So the important thing is that it's something really important that needs to be discussed with partners going forward. And there are cosmetic and psychological concerns is crucial, but lifestyle changes are still important that we need to implement. So the drug by itself is not the only solution. It's a combination of better eating, more activity, less food, and agents that control our appetite and cravings. Thank you.
Pardon me. Sorry. Had a lot of patients actually in my clinic who are on these treatments, and basically seen almost everything you've mentioned. I've got a few. I'm going to quickly ask you about a few questions. What's the position in relation to pancreatitis, and what type? Second is there's an evolving issue with vision. Can you tell me more about that? Third, what do you think about micro-dosing in the treatment of obesity? And the third thing is, I've noticed...
Pancreatitis is a very rare complication of anyone being overweight. There is really not much evidence that these agents cause pancreatitis. Should we use them in patients who've had pre-existing pancreatitis? Use it very cautiously and refer it to a specialist. I do it, but with great caution. There's no point measuring amylase or lipase in this situation because the values always rise. Second point was in relation to this very rare retinal disorder, I think described in about 40 cases out of thousands. It was a causal association that was described. As I said to someone yesterday, diabetes causes more blindness than any other disorder in the world. You jumped into your car today to drive here. The issue is about risk versus benefit. There's more risk of becoming blind from being overweight than from taking these drugs. In terms of microdosing, I've seen those papers. There's no evidence for it. But again, it may be a way as we taper the dose down in these individuals. We certainly start off low dose, and you can certainly click dose the pens to actually achieve smaller doses, and there are lots of click charts on the web that you can actually download where you can start off with smaller doses and build up or come down.
Can I ask, the vision changes, are they reversible when you stop the medication?
I haven't seen it, and I've used it in... It was basically a paper that came out of Scandinavia somewhere that basically looked at a big database and they did a cross-relation. Now, it may not have anything to do with the drug, but it's like anything. When you have lots of associations with lots of data, you get relationship.
Try number 4.
Yeah, so the other question is, I've seen quite a few that flip towards mental health issues, particularly depression, and the other one is fatigue, which is a very common problem that I've seen as well.
Just on the fatigue, don't forget your body is losing energy. It's the reason why you lose hair. Your body is losing energy. It doesn't like to lose weight, okay? It doesn't know that you're doing it on purpose. It's trying to guard against you losing weight and protect. So it's not surprising that you get fatigue, and this is where strength training is actually very important. The first part of that was around the depression. Again, don't forget, some patients, you need to be certain your patients don't have an eating disorder and other psychological mental health issues prior to starting therapy. And it's an interesting phenomenon that a lot of people who are overweight, there's an addiction component to it. And sometimes that addiction component can shift, and we see this with bariatric surgery, to other domains. But the interesting thing with these drugs is it actually suppresses your desire to drink alcohol as well as probably other addictive behaviours. And there's some early interest in problem gambling as well.
Tom?
Good morning, Stephen. Nice to see you. The hair loss thing, what's the pathophysiology behind that? Is it just a rapid weight loss? Like, why do people temporarily lose hair?
The issue, the way I see it, is basically your body's saying this is non-core function, okay? It's not necessary to survival. Shut down non-critical elements. So hair growth is not critical, so I'm just going to divert my energy to other aspects of metabolic maintenance. And again, it's generally reversible, but again, if not, we use other agents such as minoxidil.
And my final question is, when you do swap patients from semaglutide to tirzepatide and they're on 2.4 milligrams maximum dose of Ozempic, do you go straight onto 15 milligrams, or you got to be worried about side effects again?
2.4 of, the question is how you transition. 2.4 of Wegovy is probably equivalent to 5 milligrams of Mounjaro. Okay, so I would go from 2.4 to 5 and then build up. So in effect, it actually is cheaper in terms of dose to dose.
Can I ask, you mentioned before these medications cause a disinclination to eat, a suppression of appetite. Does it change taste?
It does change taste, and people say that they don't ordinarily like sweet anymore. They're not looking for sweet, rich, high carbohydrate foods. It changes their desire for certain types of food. So they can look at it and say, I'm not interested in that anymore.
So one robs a certain amount of pleasure then from eating?
Well, it's probably working on pleasure centres as well. The good news is there was a paper where libido actually increased with the drugs rather than reduced. So,
so you can eat less but have a bit more of the other?
Yeah.
Right. Over here.
I've had a few stories from anaesthetists who are friends of mine where patients have come in and they haven't told them that they're on these injectables for whatever reason, and then they've gone on and aspirated under anaesthetic because of the lack of gastric emptying.
Yep.
How long should we be telling our patients to stop these before they go in for a gastroscopy or something like that?
It's a new phenomenon. So again, because it slows down gastric emptying, you can actually then have gastric contents, and then you get aspiration, pneumonia. So what we advise these days is to be off it for at least 2 weeks. If you're planning pregnancy, you need to be off it for at least 8 weeks. And the other important thing to remember is because people tend to, females of reproductive age, if they lose a lot of weight, they become more fertile. So they need to be aware that they're more likely to fall pregnant. But 2 weeks pre-op.
Okay. Last question, this young lady. Just wait for the mic, if you would, so everybody could hear the question. Sorry.
Yep. Just want to know about the weight loss, how much the percentage should be, like ideally, and if you want to change to, because I've got a patient that losing weight but is a couple of kilos before changing to the other substance. So what's the percentage?
Again, set realistic targets for patients. So normally I would say at least 5% within the first 4 months and 10% in the first 12 months. They need to weigh themselves regularly, not just to rely on body measurements. And ordinarily, I'd say a kilo a month, and they go, "Oh, only a kilo a month." Well, that's 12 kilos a year. That's actually a great result. But again, if they haven't done anything within 4 months, then that's when I would be thinking about switching.
Do we have time for one final question?
Yep.
One question? Yep.
I've got a patient in clinic who has tried several of these different drugs and not had a ideal response or much of a response in a 6-month period. Is there a reason why that might happen for some people?
Look, again, it's not one size fits all. We don't understand all of the personalised genomic or genetic factors, but about 10% of patients don't seem to respond. Whether they respond then to switching, we're sometimes using agents such as Contrave in patients who fail in combination with these types of agents, and that's another way of actually managing it. But again, they need to go back to their lifestyle. So I go through what do they actually eat per meal? What are they really eating? Get them to bring in photographs of their meals. Some people have misperceptions of what is actually a normal size meal. Particularly my favourite hobby horse, don't do smoothies or juices or anything liquid. As soon as it's a liquid calorie, you're just increasing the absorption. Protein shakes do not make you lose weight. They make you gain weight. So all of those you had protein shakes this morning, I'm sorry.
Absolutely last question over here. Can you repeat that? Thanks.
One that works better on menopausal fat.
Sorry, is there one that works better on menopausal fat?
Look, I haven't seen a difference. Again, as I said before, Mounjaro is stronger than Wegovy. But again, there's nothing special about menopause as such. It's like when patients say about thyroid hormone, or they're all contributing factors. But without food, energy coming in, you will not gain weight. So it always ultimately becomes the amount of energy going in and the amount you burn. As I normally say to a lot of my patients, if I threw you into a North Korean jail, you'd lose weight. Okay, so it goes without saying. The big problem is then the weight distribution pattern, where the weight then persists always on the abdomen and the areas that you don't want it to persist. And again, that's because that fat there in the central part is a specialised type of fat. That's our camel's hump, and that's designed for energy storage, all right? But it's a difficult issue.
We might give Professor a rest this morning. What a fabulous keynote speaker, very polished and erudite.